بسم الله والصلاة والسلام على سيدنا محمد وعلى آله الطيبين الطاهرين وأصحابه المختارين. Assalamu alaikum wa rahmatullahi wa barakatuh. In this lecture, we are talking about acid-base balance in massive blood transfusion. You hear the statement correct acidosis all over the previous lecture. And let us now look why acidosis developed and how we clearly face what happened. There will be metabolic acidosis, most commonly during active postpartum hemorrhage. What causes it? Hemorrhagic shock. When the patients have hemorrhagic shock, there will be tissue hypoperfusion. As we know, the simple physiology, generalized vasoconstriction, conserving the blood for the vital organ. So if there will be hypoperfusion, the cell inside the organ start to do anaerobic breathing. And this will lead to lactic acidosis and reduce the oxygen delivery despite the transfusion unit of blood is controlled. Renal hypoperfusion, reducing acid excretion, and hyperchloremic acidosis if large volume of normal saline are used. So clinical finding, there will be reduce the pH less than 7.35, reduce the bicarbonate, increase the lactate for more than 4 millimole, and increase base deficit. This is the early phase. What happened later? Later, there will be metabolic alkalosis. What causes metabolic alkalosis? You already give stored blood containing citrate as an anticoagulant. Once the liver perfusion recovers, a lot of blood will go to the liver and citrate is metabolized to bicarbonate. And this bicarbonate generations can produce metabolic alkalosis, particularly after very large transfusion volume, massive transfusion protocol. Clinical finding, the pH will be more than 7.45, increase in the bicarbonate, normal on improvement in the lactate. Respiratory disorder may occur at any time. Respiratory acid-base disorder, may occur simultaneously or anytime during the cascade of massive blood transfusion. The causes could be respiratory acidosis, hypoventilation, sedation, pulmonary edema, trali, tacho, respiratory alkalosis, pain, anxiety, excessive mechanical ventilation. What will be the consequences? There will be respiratory acidosis with increase in the PaCO2 and reduce the pH, or respiratory alkalosis would reduce the PaCO2 and increase in the pH. So in summary, looking to this picture, we can summarize the acid-base disorder, either metabolic acidosis due to the hyperhemorrhagic shock and tissue hypoperfusion, and it's occur early during active phase, and we know what is the key feature from reducing the pH, reducing the bicarbonate, increasing lactate, increased base deficits. Hyperchloremic acidosis caused mainly by sodium normal saline infusion. So you have to keep in mind, once you diagnose postpartum hemorrhage, LR and serum light, it is the fluids of choice in postpartum hemorrhage to avoid hyperchloremic acidosis with low pH, low bicarb, increased chloride. Metabolic alkalosis, citrate effect, and this is occur later on. So that's why if the patient she have severe postpartum hemorrhage with massive blood transfusion, either she should be kept in the ICU or she should be kept in high dependency unit in the labor room with well-trained nurses, and it should be managed by the senior obstetrician in the team. Citrate metabolism to bicarbonate after liver perfusion recover, and this will lead to it's due to the large volume transfusion and perfusion, and you will see that there will be increase in the pH, bicarbonate, normal or low lactate. Respiratory acidosis due to the hypoventilation, trali, tacho, sedations, and it will be increasing in the bicarb and in the CO2 and reducing the pH, or respiratory alkalosis due to the hyperventilation and pain, anxiety, This is we can lead to reduce in the CO2 or increase in the pH. The key clinical message is the primary acid-base abnormality during active postpartum hemorrhage is metabolic acidosis due to shock, not transfusing blood itself. As the circulation improves, the situation will be changed from metabolic acidosis to metabolic alkalosis. Serial ABG, lactate, base access, and electrolyte should be monitored throughout the massive transfusion protocol. Monitoring the target during massive transfusion with a pH more than 7.2 to 7.25, preferably 7.35 to 7.45, which is the normal range. Lactate should be decreased toward less than 2 millimole per liter with improving the base deficit. Ionizing calcium should be watch out for any sign of hypocalcemia or hyperkalemia. Avoiding hyperchloremic, used balanced crystalloid like LR and plasmalite when possible. Classical pattern, early lactic acidosis, late citrate-related metabolic alkalosis. Thank you for your commitment to excellency in women healthcare. Together we are shaping safe care, improving outcome, and supporting every woman at every step.